surgical gynecological oncologist, and I'll be talking about advances in surgical gynae-oncology. And please do let me know if you have any questions by the end of the session, please. And I'll be talking about the most commonest cancers, which are the endometrial, cervical, and ovarian gynaecology. And as an outline, I'll talk about each and every cancer, and then how we've moved on from in the last one to 2 decades in our approach in managing them. First, coming to the endometrial cancers, I talk about the approach and have we got any fertility preserving options, how have we moved on with nodal dissections for low-grade tumors and early-stage tumors, and the role of sentinel lymph nodes, which is coming very recently, and cytorectal surgeries for advanced cancers. Coming to the approach, for the last 2 decades, initially the gold standard was to do open surgery, hysterectomy, bilateral salpingo-oophorectomy, and pelvic lymph nodal dissections by open methods. In the last 2 decades, we moved on to a minimal invasive surgery, which is laparoscopic surgery. And now, with the advent of robotics, we're moving from laparoscopic to robotic surgery. So we all know that minimal invasive surgery is more superior in view of morbidity, quality of life, return to work with less number of complications, decreased hospital stay when compared to open surgeries. And with the advent of robotics, which is another form of minimal invasive surgery, and then it's now taking over laparoscopic surgery, as laparoscopic surgery has got a steep learning curve. To master laparoscopic surgery, you need at least 90 surgeries, but in robotics, you need 20 surgeries to master robotic surgery. There's lots of advantage for the surgeons to move from open to robotics, and that's the reason surgeons who are actually not well used to laparoscopic surgery can move from open surgeries to robotics. This is how a robotic platform works. This is, we have a robot, a vision cart, and a surgeon's console. And surgeon sits at the surgeon console with foot pedals, finger loops, and then with the wrist movements and the finger loop movements with this vision in the 3D vision, the surgeon moves the finger loops, and then the robot is docked onto the patient here. Then surgery is done with the mimicking movement of the wrist and the fingers here. Because of the advantage of having a 3-dimensional view, magnification, the dexterity to get, and the individual and the surgeon's independence of the entire robotic system, because they'll be using 3 instruments, 1 camera, and then there'll be 1 port for the assistant as well. With all this, as you got full control over the entire system, you'll be able to produce better results. So moving on to then next is the sentinel nodes. Sentinel nodes came into picture because as we knew that systemic lymphadenectomy is so morbid in view to complications into the pelvic side wall, lymphedema, and so many other complications post-operatively. And sentinel lymph nodes, we have developed it for, we use near-infrared cameras, use ICG or methylene blue. It's one of the cameras and the near-infrared system, which was developed in Oxford when I was a fellow, and a publication was done on this. This is the robotic platform where they use the ICG, and they inject the ICG into the uterine corpus, and then use the cameras to identify the sentinel lymph nodes. And this is the near-infrared camera on the laparoscopy with ICG. So this is the literature. You could see the comparison of operative outcomes, meta-analysis from laparoscopy to robotics, which has shown that robotics is much superior to laparoscopy in view of the decreased hospital stay, blood loss, and complications associated with it. And this is the publications and of the systematic review and meta-analysis that sentinel lymph node assessment in endometrial cancer. In early cancers. So moving on, we know that Mirena coils have come into treatment for atypical endometrial hyperplasias and grade 1 endometrial cancers, and does help in women in fertility preservation. So this is how Mirena coil is, progestogen releasing coil, which is used for typical endometrial hyperplasia, for fertility preserving options, and for G1 endometrial cancers. And there's other ways that you could treat somebody who's got significant comorbidities by doing a gastric bypass. And then, as we all know, that peripheral excess estrogen stimulates endometrial hyperplasia, and this is post gastric bypass and having a Mirena coil inserted. This is how the endometrium is looking. So we could conservatively manage them with these new advent of hormone-releasing coils. Next is coming to cervical cancers. As we all know, that treating any cancer depends on the stage of the cancer, the type of cancers, and the comorbidities you have. So within cervical cancers, the few things that's come up new is trachelectomies, which are fertility preserving options, and then doing frozen section on lymph nodes, and then doing it as a two-step procedures, and then doing total mesometrial resections and therapeutic lymph node excisions for node-positive cervical cancers, avoiding radiotherapy as a treatment, and then laterally extended endopelvic resections for recurrent cervical cancers which have recurred post chemoradiotherapy. This is radical vaginal trachelectomy. You approach it vaginally in the cervix, the upper part with vaginal margins with paracarpium and parametrium, and then you reach a uterine isthmus to the cervix, to the vagina. This is a picture showing the abdominal radical trachelectomy, which is usually done for tumors greater than 2 centimeters, and it's as a part of a trial. So I've spoken to you about trachelectomy as a fertility preserving options with abdominal and vaginal approaches, and then coming on to radical hysterectomy. So far with this new LAC trial, which was published in 2018, we've changed our approach from minimally invasive surgery to open surgeries, and few other papers have been published with retrospective analysis of all Canadian data, British data, and American data, for which we now moved on to open radical hysterectomy. And then I'll talk a bit more about total mesometrial resections later and extended endopelvic resections, which is for recurrent cervical cancers going into the sidewall. So nerve sparing is an important aspect because it helps in preserving bladder, bowel, and sexual function. This is a laparoscopic picture. This is the ureter here. This is the inferior hypogastric nerve, pelvic planktonic plexus, and they join up becoming inferior hypogastric plexus there, which is very important, and it's not easy to identify, and you need significant magnification, especially with the laparoscopy, to do nerves preserving procedures. So this is sentinel nodes similarly, and we could use it like 2 settings for trachelectomy when you're doing a vaginal trachelectomy, or if you wanted to do it in a two-phase fashion by doing lymphadenectomy first and sending it off for frozen section, that would be quite helpful when you're doing sentinel lymph nodes, and then you stop if it comes back as positive, so that you prevent dual modality treatment. As we all know that if any node positive disease, we give chemoradiotherapy. Coming to total mesometrial resections, this is a procedure which was developed by Professor Michael Huckel from University of Leipzig in Germany. They had a hypothesis that cervical cancer spread in embryologically derived compartments and to its regional lymph nodes. And with this, they said the hypothesis that if you take these derived compartments and the total mesometrium, you get significant local regional control. And doing a therapeutic lymphadenectomy, where they take not just the pelvic lymph nodes up to the obturator nerve, but they take it below the obturator nerve, and then they take the presacral lymph nodes, pregluteal lymph nodes, and then they go up to common iliacs at the level 2, and then parietic nodes at the level 3. And the results are quite significant, and this is avoiding radiotherapy even to node positive cervical cancer, that you could achieve 87%. This is, overall survival, 5-year overall survival with node positive cervical cancers. This is a typical specimen of a radical hysterectomy, and this is our TMMR specimen looks. Coming to laterally extended endopelvic resections, these are done for side wall recurrences or central recurrences going up to the side wall, where you take the interiliac system with the pelvic floor muscles in order to, if you get an R0 with these, and then you'll be able to get around 65% 5-year survival, because these are all previously radiated patients. Previously, there was no option for them, but this was a procedure developed from University of Leipzig where you could give 65% 5-year survival chances for somebody who's record post radiotherapy or some with sidewall recurrence. So these are some of the publications which we did from Oxford. We routinely do intraoperative frozen section to prevent dual modality treatment. We take all the lymph nodes out and send it off for frozen section. If anything comes back positive, then we stop there, and then so that it prevents dual modality treatment. Lots of publications from Leipzig and Lancet about extended mesometrial resections, lateral extended endopelvic resections, and total mesometrial resections with therapeutic lymph node excisions. This is what has actually changed our approach to cervical cancer. This is the LAC trial. It's a randomized controlled trial done in several centers in the world, but mainly from Anderson, which they try looking open radical hysterectomy with a laparoscopic approach or robotic approach to cervical cancer, which actually proved that open is got better overall survival and disease-free survival. And this is the Canadian retrospective analysis from national database, and this is the American database, and this is the British, which all showed open is more superior in overall and disease-free survival compared to a laparoscopic approach. Then ASCO released the statement that open approach is the gold standard, and the same thing with the British Gynaecological Cancer Society, and same with the NCCN as well now. So gold standard now is to offer open radical hysterectomy. Then moving on to ovarian cancer, we all know advanced ovarian cancer is very challenging, and most women, at least 3/4 of them, usually present very advanced. This is how they usually spread. This is diaphragmatic disease. This is a mental disease here. You see extracapsular spread going into the bowel. And this picture is previously endometriotic cyst, now turned into a clear cell carcinoma and invading the uterus, rectum, and the sigmoid. So where we have advanced in ovarian cancer, we've changed our surgical paradigm, adding up more upper abdominal surgery. Previously, we thought optimal site reduction was only achieving anything less than a centimeter. Now, R0 is the nothing visible at all is the goal standard to achieve. And we're now offering secondary site reductive surgeries for recurrent cancers. With now HIPEC is heated intraperitoneal chemotherapy we give at the time of interval site reduction or primary site reduction to achieve better survivals. And then there are thoracic resections done for cardiophrenic nodes, and we've moved on from primary to interval to delayed primary debulking, depending on how extensive the disease is, with assessments in between. And then we use minimally invasive surgery for stage 1A, and there is a few other studies that's been published for advanced ovarian cancers, the role of laparoscopy and robotics post-chemotherapy. So this is the landmark paper published by Bristow with around 7,000 patients for stage 3 and 4 ovarian cancers, which actually changed the approach to surgery in ovarian cancer. It said that every 10% increase in maximal site reduction is associated with 5.5% increase in median survival time. This paper has been cited more than 2,000 times in Gynaecology. And this is what actually showed much difference to surgical paradigm, and moving on from R1 to R0, adding up upper abdominal surgery. Now we said radical surgery, ultra radical site reductions. And then this is meta-analysis supporting secondary site reductive surgery for recurrent ovarian cancers. These are some of the pictures we do, and for the surgeries we do. This is diaphragmatic peritonectomy, mesenteric peritonectomy. This is the resections at the porta and porta hepatis and hepatoceliac lymph nodes. This you could see the pleura, excision of the diaphragm with the pleura, and this is laparoscopic approach to advanced ovarian cancers confined to the pelvis. We'll be using these endo staplers. So these are some of our publications from our group. I was co-author for some of them in ovarian cancer from Oxford, where this is a paper about diaphragmatic surgery. This is the role of intraoral laparoscopic surgery for advanced ovarian cancer and for disease of the porta. It's one of the papers which showed 90% optimal site reduction with R0. This is one of the big series published in the world with a good optimal site reduction. So HIPEC, what we do in HIPEC is after achieving optimal site reduction with at least R0 or maybe less than a centimeter, we infuse medication for around 90 minutes at 42 degrees centigrade in a view that all the cells would be subjected to the hypothermia, and then even the heated chemotherapy reduces the surface tension, and there will be better survivals after that. So this is the randomized controlled trial, which was published from Netherlands, showing significant overall survival around 11 months for advanced ovarian cancer. This is a systematic review and meta-analysis supporting both in primary and recurrent settings. Thank you.